Can you hear me, Dr. R? Hello? Good morning. Okay.
Hi.
Good morning.
Good morning. Good going. That's great.
Oh no, a lot of traffic on the way over here. Okay. We are live. It's really nice to see your face.
You too, Carolyn.
Thank you, Dr. Rosensweet, so much. And yes, lesson in Computer 101. I have these great questions, and I have even better ones for next week. I'm like questioned out here. It's great. May I start?
Please, yes.
Okie dokie. So, number one, I'm new to the group, and I'm wondering what your thoughts are regarding using a high dose of testosterone with the hope of its converting to estrogen. Is this something you've heard of, and is it okay to do? Oddly, she says, especially for those of us who cannot tolerate progesterone.
Well, there's been some heavy lessons learned in the world of, quote, high doses of hormones. I mean heavy.
Yeah.
For one thing, hormones are the most powerful biochemicals we've got going on. And the body goes way out of its way in natural circumstance to have careful regulation and keep hormone levels within appropriate bounds. Not too much and not too little. And it can go offline. I mean, stresses are the most common pusher into too much coming out of the glands themselves, because these hormones are so powerful. They contribute greatly to fight or flight. So even young people can get increased levels of hormones and can get into hormonal balance. But hormonal increase and hormonal balance or hormonal excess is never good. Okay, if you're constantly facing saber-toothed tigers, okay, one could make a case for really robust levels coming out of those glands, but not in the long run. The glands won't be able to keep it up. So I'm giving you just a general overview of excessive doses of the most powerful biochemicals in our bodies. Wrong strategy. Now let me tell you about a lesson. I was in medical school in the mid 60s, and I left medical school with fear of one substance. Not pharmaceutical drugs. I had fear of one substance. It was cortisol, the most important hormone in our body. We need it to live. Cannot remove someone's adrenal glands. We will not live if we do not replenish cortisol. You can remove a thyroid gland. You'll be in bed probably permanently, but you'll still live. But you cannot remove cortisol. And what happened in the 50s, I think it was in the 50s, I'm not sure about this, they learned how to produce cortisol, and doctors started giving it to patients, and it became so popular. Oh my God. Because people were low in their adrenal glands, and you start replenishing cortisol and people feel better. And cortisol's got this unusual, quote, side effect of people get high. So people who go on long-term steroids like prednisone,
I was just going to say,
it's hard to get them off of it because they get high from the prednisone. And so meanwhile, there was several years in there in which these corticosteroids were being prescribed in just phenomenal amounts. Very, very popular, until they started noticing that there was these side effects taking place. Fat redistribution, buffalo hump, moon faces, suppressed immune system. It was a nightmare for the medical profession because they didn't know.
right.
They didn't expect it. And these were all about overdose. And in the 70s, a medical doctor wrote a book saying, look, it wasn't about giving people cortisol. Many people needed it. It was about overdose. Don't overdose with these powerful chemicals, powerful biochemicals. So by the time I was in my pharmacology courses in medical school, they really want to impress upon us is don't ever do that. Do not give excessive doses of these things. And I left with fear of one drug called cortisol, which was actually a hormone.
Meaning you graduated medical school, but you graduated with that in mind.
The fear of one drug.
Yeah.
Because of how damaging it was to the American population. Now, testosterone isn't, I'm sorry to be so melodramatic about it, but I do want people to get my true opinion. And my true opinion is you don't mess with overdose with these powerful biochemicals. And your body's going to try and prevent you from messing with overdose. You give too much testosterone, your body's not going to like that. And your body's got some protection mechanism of itself from excessive dosages. It produces these proteins that bind up the excessive levels.
Right.
And the protein that it uses is a protein that functions normally as sex hormone binding globulin. And so your liver produces excessive sex hormone binding globulin to bind up what it reads as excessive testosterone. It'll also do that with excessive estrogen. Now, you give someone excessive estrogen, you've got a real good chance of increasing their sex hormone binding globulin as the body tries to bind up and protect itself from your overdose. Increasing sex hormone binding globulin is a really slippery slope. It can lead to the most challenging menopause situations I've ever gotten into, actually, to assist people with, because you give them more hormone and they increases their sex hormone binding globulin because their body is really used to doing that. We first learned this with the birth control pills, where you got a young woman in her 20s at the absolute maximum output of her ovaries, maximum output of estradiol, for example, and you're giving her estradiol in the birth control pill. Well, a lot of these young women, they read that as that's too much estradiol. Their bodies read that excess, and they try and protect the young women's bodies protect the young women from the increased levels of estradiol, and it increases the sex hormone binding globulin. And sure enough, it binds up the excessive estradiol. It also binds up testosterone. And a lot of these young women on the birth control pills surprisingly lose their libido. Not all of them, because they bound up their testosterone too. I'm giving an example of the internal protection and that the body does not like excessive doses. And, to me, it's like absolutely wild. Someone looks at a biochemical roadmap and sees that testosterone can convert to estradiol. It does not mean if you give someone, an individual, testosterone, it's going to convert primarily to estradiol. Just because it shows up on some theoretical roadmap, yeah, that does operate. But we never, I never, like I could say, just take cholesterol. It will increase your estradiol and your estriol, because all these hormones begin as cholesterol and they're biochemically converted. Let's just give everyone cholesterol. Just take more butter and you'll be fine. No, you have no way of controlling what it's going to become. Or some people have had the idea, we convert cholesterol to the first hormonally active biochemical called pregnenolone. And pregnenolone is converted to estrogens, testosterone, progesterone, corticosteroids. Pregnenolone. Why don't you just give people pregnenolone in menopause and give men pregnenolone in andropause? Because we have no control of what's going to become. We don't know that pregnenolone we're going to give that woman is going to turn into the amount of estrogen her body needs. It could convert to testosterone. It can convert to DHEA. So it's a fundamental principle in the menopause method is don't be giving people precursors.
Yes.
You have no control over them. Give them the hormone that they are low in. and replenish it to optimal levels. So I'm sorry to be so intense, but I've heard these wild strategies out there, and I'm not here to criticize you for them, but to me, they're just like it's an example. And I think why my feelings get stirred up is we're under a lot of pressure in the world of treating women in menopause. Women just don't understand that in a flash, they could lose all access to the good hormones and be left with mediocre hormones, in my mind. And mediocre is better than nothing. But there's a campaign to get rid of compounding bioidentical hormones. And when I hear these, and they're gathering their evidence, and they're a storm. And I'm talking about the government agencies that have the ability to shut these down. And so when I hear these wild ideas that are going on out there, I don't mean to be harsh. I know women are scrambling for some kind of way into alleviating the challenge of menopause. But I can't circumvent in this moment and be honest that I'm not stirred up and I'm uncomfortable about this kind of stuff. And when I go onto Facebook and I hear the opinions that are being thrown around out there, it's very upsetting to me because it puts everyone in jeopardy. All traditional doctors have to do is hear about something like that, and they go, see, these compounded bioidentical hormones, they're terrible. These people are coming up with the wild ideas. So I apologize for my own upset, and at the same time, I want you to hear it. It's time for us to clean up our act here, and just really, your job becomes the same. It's imperative that you as a woman find your way to someone who knows what they're doing, is taking this on as a specialty, and doesn't have these circuitous ways of dealing with something that's, yes, it's challenging. We're balancing 4 hormones in a woman, and we bring in thyroid, etc. But at the same time, it's very doable. It's not even rocket surgery. It just takes patience and, figure it out. But apologize, folks.
No, and that's what makes you so very, very special, Dr. Rosensweet. You always give us your best shot. You always give us the truth. And it's really important that we hear that, and we can segue off into the coalition and get me all riled up. And I don't want to do that. People know where to go, and there are a lot of them out there. And we're yes. So please hear those words. It's so important. We got to do this right, and we don't want to give anybody fuel for the fire, so to speak, right?
Yes. And the final thing about testosterone, I see that it's not uncommon that women are put on these supercharged levels of testosterone. And yeah, you can get high on most any hormone. And you can get high on other things. I don't even have to name names here. But it's a real lousy strategy for life and health. And eventually it takes you out. Think of all these athletes that they put themselves on steroids. What kind of steroids we're talking about? Muscle building steroids, some kind of theme and variation about the androgens and testosterone. Men lose their erection in their 30s from being on these excessive levels of steroids. It gives you women a perfect example of what the heck can happen to you when you're messing with a wrong approach. What are you going to lose? What are you going to lose? What's consequences? I have a woman patient right now. She's really challenging. She got used to high levels of testosterone by injection, and it's quite a challenge to wean her off of this. And we haven't even succeeded yet, and we're probably 6 months into the process. And she's seen the levels on 24-hour urine hormone tests. So anyway.
Okay, well, that is for someone new to our group. Welcome. I hope you'll stay. Oh, my God. You'll get used to it, honestly, and it's all good. We love you too. On to question number 2. Oh my God, Dr. Rosensweet, David Rosensweet. So, here we are at Testosterone Tuesday, Thursday, whatever. Good answer.
Mm-mm.
All right. I have a question about, I don't even know this word and I apologize. A question about T virilization. I have been on BHRT the past 4 years. I'm postmenopausal, 57 years old. I've had bleeding, but all of my tests are, the transdermal vaginal ultrasound, everything's coming back normal. I am, however, taking 25 milligrams of DHEA, which I know you're not thrilled with. I'm having horrible vaginal pain, and I'm wondering if these symptoms could be coming from too much testosterone and too much DHEA converting to high testosterone.
Well, when in doubt, we've got this phenomenal tool called 24-hour urine hormone testing. I'm not talking about other kind of urine testing. I'm not talking about saliva. I'm not talking about blood. We have 24-hour urine hormone testing. And when in doubt, well, just we test. And we have reference ranges. We have reference ranges, for example, of what young, healthy women, what their levels are. And I've gone in and extrapolated from the medical literature what safe reference ranges are for women in menopause, and they are less than young, healthy women. You don't need to menstruate. You don't need to once a month cause breast glandular cell proliferation from robust levels of estrogen. You don't need breast glandular cell mitosis once a month. We know what menopausal levels are for most women in most cases. There are exceptions. Some women need significantly higher doses for very special reasons. So when in doubt, we test. And then we get to look at the abnormal hormone profile you're probably having. And that's a good place to start. There's another good place there's lots of ways to start. I mean, in the menopause method, the first thing we issue to a woman is this very extensive questionnaire. And we learn a tremendous amount about her. And usually the clues are right there in the questionnaire. The question is, oh, look at that. She's probably got excessive androgens. We learn about it from the questionnaire. And that's where we start. Or there's another place that we start. And I do this so commonly. When in doubt, stop all your hormones.
Mm-hmm.
See what happens. If that vaginal pain goes away or that pelvic area pain goes away,
Right.
guess what? It's related to those hormones. It doesn't mean you don't need hormones if you haven't had a period. And if you're 57, your ovaries are not what they were in their 20s. And if you're not having periods, you're super low on estrogen, testosterone, etc. Now, you've heard me say on this program, obviously the questioner has, and I've been blessed with mentors. And I'd like to shout out to Dr. Alan Gaby, a pioneer in the world of DHEA. And he said to me, no woman should ever be on more than 15 milligrams of DHEA orally. But what do you know? He's right. And a lot of women shouldn't be on 15. They need 12 and a half or 10 or even 7.5. Because of just the way that they process DHEA. 15 can be excessive for them, but he said no woman should ever be on more than 15. Why did he say that? Because he had a lot of experience.
Obviously.
A lot of knowledge.
Right.
Right out of the gate, there's 3 areas that we would evaluate you. One is through hundreds and hundreds of questions, 12 pages of questions. It'll give us a real profile. Or if the word 15 alone tells me, oops, there could be problems there. And then, hey, want to find out if your pelvic discomfort is caused by the hormones you're on? Stop all these hormones. There are certain medications that people take that it is very unwise to stop them cold. I can
Yeah.
think of, I can think of blood pressure medications that you don't want to stop a blood pressure medication cold, especially if you're in a danger zone. Someone who's on insulin, you don't want to just stop your insulin. That could cost you your life. There are several medications that we don't stop cold. Even something like Xanax, a benzodiazepine tranquilizer type of thing, whatever you want to call it. You don't stop Xanax cold in most people. They have it's like stopping. It's one of the worst things to stop cold. Having said that about Xanax, certain medications, that's not true about hormones. You can stop them cold. Now, in the first place, they're all fat soluble, so you've built up some in your fat. So one of the things that's going to happen is when you stop taking hormones, the hormones that are in your fat are going to trickle out into general circulation. And so it's not going to be that abrupt. But the worst thing that's to happen is you're going to return to some hormonal deficiency symptoms. You're not going to like that, but it's not like stopping a blood pressure medication cold. You'd have no worries. Stop it.
Right.
You stop taking your hormones. See what
It's okay
happens
to do.
if some of these things disappear. You know it's related to hormones, but it's usually related to inappropriate doses, too much or too little. So the job is always the same. It's find a healthcare professional that can prescribe hormones to you that really knows what they are doing. They've taken this on as a specialty. You're dealing with some of the most powerful biochemicals that can be administered. And because they're so powerful, we need those. Our bones, our arteries, our brains, women's vaginas, men's erectile function, men's muscles, women's muscles, energy, libido, metabolism, everything depends on these, are heavily influenced by these powerful hormones. So you want to get someone who really knows what they're doing.
Right.
You don't go down to your local Mexican pharmacy and because you got diabetes and say, "Give me some insulin, would you?" And you've never been to a doctor and you start playing with insulin. You don't do that. You want to find an endocrinologist or an internist who really understands how to administer something so potent as insulin and really can teach you how to do it. And you can then the two of you team it and you figure out what's the right timing and what's the right type of insulin and what's the right dosages. You do this in concert with a professional who's taken on diabetes as their professional life's work, because you're playing with fire there. And the same is true with hormones. So what I'm going to say to you is something's off, and the way to find it is find a professional who really knows what they're doing. That's the challenge these days. It's go shopping or just cut right to the menopause method. If we have someone in your state, you get to interact with someone who's in our either already trained up or in our training program. So yeah, that's the job of all women. Go shopping. It's a shopping trip.
It is. Yo,
You really got to go shopping, and you got to be willing to do what you do with other kinds of shopping. Go try it out. Oops, wrong thing. Get me to the next place, please.
right. And like Jim Hernser so beautifully says, is just say thank you. I really appreciate your time and then move on. And
Yeah,
just
right.
you know, I mean, that's how it is. And yeah, yes. Okay. Well, thank you, Lee. I see you. Good morning, and Sarah. Good morning. See your questions. We'll get to them. Okay. Question number 3. I had a horrible time tolerating progesterone. I get horrible. This is an interesting question. I get horrible breast tenderness, cramping, aching ovaries, weight gain, and spotting with very low amounts of pee. So what I did is I went really high. I got an over-the-counter cream of progesterone. I went up to 100 milligrams then to 175. My goal is to get to 200, and I actually have relief. Dr. R, have you ever heard of this? Someone not tolerating low amounts of progesterone, but able to tolerate higher amounts. I am feeling a lot better. And finally, I'm having breast relief. I am taking a thyroid hormone, T3, but I feel I can now back down on it. And I would appreciate any thoughts you might have.
This is a very interesting situation.
I know, huh?
There's several questions embedded in it from my perspective that there are women who do not tolerate progesterone, at least at first. And it's always been quite a mystery to me because a young woman's body has 100 times more progesterone than she does estrogen, for example, milligram for milligram. And yet there's some women, when they go into menopause, they can't tolerate progesterone. The thing that's fascinating to me is that the questioner took a leap and decided, I'm going to increase my dosage. That's fascinating to me. I've never heard of this approach, and it inspires me to check this out in clinical practice, because I have never thought to get more aggressive. I've only thought to go lighter and lighter and lighter and lighter, thinking that if she doesn't tolerate the usual doses of progesterone, I'll start out with a 20th of the original concentration, which I've done, or a 40th. For example, in our organic oils, the most common starting progesterone prescription is 200 milligrams per milliliter. Well, I've had women who don't tolerate that dose, so I've gone as low as 5 milligrams per milliliter. This is a very, very low dose of progesterone.
Right.
It's about 0.25 milligrams of progesterone actually delivered per drop. This is a very small amount of progesterone. It's almost homeopathic. It's so small. And that's the approach I've used. I've never thought to go to robust and supercharged levels of progesterone.
I don't think any of us have.
And I want to thank the questioner here, because I hear you and I believe you, and it's opening up a new possibility for me. And I'm going to I'm lingering on this, because this is the gift of working with patients, is I can learn, I can continue to learn, because she's proof. She just told us that she went to high levels of progesterone and it worked. That opens up a whole new avenue of possibility in treating what is not super common, but fairly common, a inability to tolerate progesterone. And I'm going there, and I want to thank the questioner for this.
Absolutely. And she put that out there. And I said, may I ask this question? It's fascinating to me. It would never occur to me either to, you know.
Now, having said that, there are some questions, and I'd love if the questioner would please email me directly.
Oh.
drr@menopausemethod.com. I'd like to learn more from you. drr@menopausemethod.com, because over-the-counter progesterone does exist, is legal, and is present in very small, what I would call 2-week for most women in official menopause. For example, over-the-counter progesterone is commonly 1.8%. or even 0.2 or even 2%, which is 1.8% is 18 milligrams per milliliter. Yeah, creams and gels, you can when I was prescribing gels 15 years ago, 25 years ago was my first gel, I used to prescribe 3%. That's 30 milligrams per milliliter. So the only thing you can get over the counter is 18 milligrams per milliliter or 20 milligrams per milliliter. And you know what? In a perimenopausal woman, that can do a lot of good.
Mm-hmm.
In fact, we encourage perimenopausal women, if you understand the symptoms and go to Happy Healthy Hormones, our book, you'll understand the symptoms of progesterone deficiency and how progesterone often declines earlier and deeper than estrogen. So if all young women in the perimenopause got onto over-the-counter progesterone, they could do some good.
Absolutely.
But this questioner says that she got over-the-counter and she got 100 milligrams of progesterone. This is what I don't understand, because progesterone, even prepared by compounding pharmacists, the most you can do is 200 milligrams per milliliter, and you need special strong solvents to do that, or you put it in a suspension like we do. But the over-the-counter, the prescribed creams, a common progesterone it's not even the most common progesterone, but it can be 100 milligrams per milliliter. But that's prescribed. That's a compounding pharmacist makes that up. That's not
Right.
available over the counter. So there's some mysteries, and it's why I want to communicate with this questioner directly, because I'd like to get the details, because this could help a lot of women. Now, Dr. Lindsay Berkson has been very curious about this unusual sensitivity to progesterone that some women have. And she's discovered an old colleague and friend, oh my God, the father, I call him, of bioidentical hormones on the planet Earth, Dr. Jonathan Wright. His laboratory works with women who have this peculiar or this uncommon progesterone insufficiency. And it's Meridian Valley Lab. And they test women's saliva, is what I understand. I've just learned about this, so I haven't done it yet. And they come up with strategies to deal with this progesterone sensitivity based on testing the woman.
That's fascinating.
Meridian Valley Lab, Dr. Jonathan Wright, WRIGHT. He's the one, along with Jim Hertzer, I think they did it simultaneously, brought bioidentical hormones to the planet Earth. That's something.
Copying nature.
80s, 1980s, early 80s. So, yeah, there's ways to deal. So I have questions, because I'm just so totally unaware of when she says 100 milligrams. Like if a woman were to take 100 milligrams of oral progesterone, or even 200 milligrams of oral progesterone, or somewhere in between, you can produce some significantly high levels of progesterone in a woman's body. But that's oral, and she can't get oral over the counter. She can get prescription, even pharmaceutical manufactured, sort of bioidentical. It's micronized progesterone, but it's got a bunch of other stuff in that pill, including peanut oil in that capsule. But that only comes in two doses, 100 milligrams and 200 milligrams. And that's not over the counter. You need a licensed prescriber. So there's mysteries here, but I'm fascinated. And there's this concept in pharmacology called the pharmacologic window. And you name any herb, medication, pharmaceutical medication, hormone, any substance that we can take into our body, we got to get the dosage right. And the pharmacological window could be pictured like this. And if we come in too low, we will not get the effect. However, if we come in too high, we will not get the effect. Or we'll get a paradoxical effect. If we come in too low, instead of getting a beneficial effect, we'll get an adverse opposite effect. That's why it's called a paradoxical effect. Or we come in too high, we won't get the effect of the substance we're talking about. the hormone, the medication, we can get a paradoxical, weird, unwanted effect.
Right.
It's called the pharmacological window, and we got to nail it. We got to get in that zone where my eyeballs here are. We got to get in that zone right in there where my eyeballs are wiggling. Not too little and not too much, because paradoxical effects abound, and someone gets totally blown away. I took too little and I had these weird side effects of excessive. No, you just had paradoxical effects from an inappropriate dosage. So, yet another simple question that's got a lot of moving parts.
They all do, and it's just incredible to me. So I'll go ahead and move on to number 4, which is always a biggie. But I like that last one for sure. And I like this one. Questioner says, I am just terrified of gaining weight. I've been off and on BHRT for over a decade, and I truly feel it contributes to my weight gain. I'm now addressing my thyroid, and I'm taking medication for it. My androgens tend to run high naturally. When I add in estrogen and progesterone, I gain weight, and I don't know why this is. And I'm wondering if you can help to explain this. I'm laughing because it's not an easy question. It's not because of the question, just weight gain for all of us.
I thought this was known as the Carolyn Shapiro Easy Question Hour.
I usually put that out there, Carolyn Shapiro Easy Question Hour, with the very easy answering Dr. David Rosensweet. And here we are.
Now, I probably misheard something. How many decades did you say she was on hormones?
She said for a decade.
Oh, a decade.
Yeah, off and on. Yeah.
I heard 8 decades, and I thought, wow, that's an all-time record.
Well, yeah, we do know a couple of people who were 8 decades in.
8 decades on hormones.
Yeah.
Well, invariably, if you're not, there's only one result that we accept in menopause treatment. There's only one. And that is a woman feels better and likes what's going on.
That's a nice feeling.
That's the only time you know that it's right. There aren't these side effects or these oddball effects. And when a woman's not saying, wow, I really like this stuff. Whoa, this is really changing my life. Oh my God, I feel like myself again. When that's not happening, something's wrong.
Right.
And the human body at midlife can have a lot of things that have built up that result in some problems. And when we're thinking menopause, as we often do midlife, it's a great place to start. As I've said several times, no matter how many symptoms a woman has, treat the menopause first and see what's left.
Right.
There can be things left. And especially with weight gain. Because in the last chapter of our book, Happy Healthy Hormones, it's all about weight. And it's not even an exhaustive study of weight. There's a lot more known about weight these days. But one thing is, I would make a guess that it'd be highly unlikely that the woman is on an optimal hormone program.
Right.
Because the only result when you're on the proper dose of biased testosterone, progesterone, DHEA, is the only result that we accept is normalization of metabolism. Normalization of the biochemical processes that result in energy and heat and don't accumulate weight. They keep the weight stable. So if the weight's not stable and it's related to hormones, there's something wrong in the hormone program. And there's so many things that can go wrong. You can have insufficient hormones. Let's just talk about the ovarians. There's 4 of them, but it's good that the patient threw in thyroid, because thyroid midlife is so commonly low as well. So you got 5 hormones there, and you can have too much of all of them, or too little of all of them, or you can have too much of some and too little of others, or they can be out of balance for the individual women. So there's a lot of treatment errors that can take place. And if you're not doing the 24-hour urine hormone test, I have a strong opinion about this. There's no way you really get to know unless you're doing a 24-hour urine hormone test. Now, people will challenge me on that. There's people who have their favorite other testing, but I'm still going to say that you don't get to know what's going on at this day and age unless you're doing a 24-hour urine hormone test.
Yes.
And then as far as weight goes, there's another major elephant in the room. It's the glucose regulating mechanism. Because when you eat food, your body's going to either distribute that food, break it down into tiny, tiny molecules, and distribute it for all the body needs in a beautiful sense. And it's not going to have to store anything, i.e. as fat. Because that's what it'll do. If it's got excessive calories, excessive food in there, it's going to store it. It's either going to burn it for energy,
right,
or turn it into body parts that it's recycling, or it's going to store it. And there's the whole storage mechanism is so related to carbohydrate regulation and insulin. And so I'm going to invite you to read that in the book that you can download for free, the description of how insulin, because midlife, people, most of us abuse our insulin glucose regulating mechanism over the course of our lifetime through stress and through inappropriate eating. If we eat too many simple carbohydrates, sooner or later, we're going to really wear down that glucose insulin regulating mechanism, and stress will do it too. And we get insulin resistance, and it's a perfect recipe for weight gain. So I want to mention that because biologically, there's other things that can relate to gaining weight, but I want to mention the 2 big ones in a midlife woman. It's hormonal insufficiency or imbalance, and inaccurate and inappropriate replenishing. And it's the messing with the glucose insulin regulating mechanism. And you usually do that through diet and stress. So many women that we meet in our practice, they've really worked on the diet, stress, and exercise piece, or at least the diet and the exercise piece. And so it's frustrating. But that's where you go. That's where that's what matters is in the world of weight. It starts with the big stuff. And in a midlife women, it's the hormones, 5 of them, plus the corticosteroids, so 6, and the glucose insulin regulating mechanism. And of course, exercise and diet, because you're eating wrong, you're just going to challenge the insulin glucose regulating mechanism more, or do other challenges.
Right.
So there's a piece of work.
Yeah. Kind of hard to give up old habits.
Takes you to the same bottom line. You can learn a lot, and especially around nutrition and eating properly for your body type. And sometimes it takes some major discipline to do that. And we describe the bottom line there in the book around nutrition.
That book.
Some very simple, practical things that if you implement them over time and you don't hassle yourself along the way, you'll get yourself on a really excellent nutritional part. Then there's the stress part, and then there's the ovarian and other hormone part.
Right. Thank you.
Yeah.
I'm learning a lot about all of that, and then having to go through it myself. Old habits die hard, kind of. But it is doable. It is. It's a good question. And I have a question that came up from Lee, and this is something you and I have discussed quite a bit. You talk about it anyway, and she says, "My doc never wants to test. Always says, 'Let's go by symptoms.'" Ugh. Um, and I'm wondering if you might address that and how it is.
Well, it's this quirk. Medical testing is so sophisticated and so useful. And doctors are used to that. They're used to, you want to assess about diabetes? My God, there's some great testing you don't do. You want to test about coronary arteries? There's some great testing you can do. On and on and on. The world of hormones, there's a real issue around testing. And the traditional physicians are trained that in a woman in menopause, number one, there's no need to test.
Correct.
Symptom alleviation alone will tell you what is the right dosage. And they also say, and we're talking about the North American Menopause Society, we're talking about the American College of Endocrinology, we're talking about these major professional organizations say don't test a woman in menopause, just go by symptoms. And that's what most doctors are trained in. And they say, for one thing, salivary testing is way too whack-a-mole and doesn't work. And they say when you're treating a woman, blood tests don't work. And they're right. But what they're not aware of is 24-hour urine hormone test, even though it's been around, certainly in the late 60s. There was an oncologist who did some brilliant work around testing 24-hour urines of women who had breast cancer and women who didn't. And this doctor tested the estrogens and other hormones as well. This has been gold standard. But it's still, even though it's been around so long, there's a very, very, very small percentage of physicians who are aware of it, let alone willing to do it. And there's several reasons why they get reluctant to do it. For one thing, when you look at a test report of 24-hour urines and metabolites, there's like 15, 20, 25 numbers. And there's biochemical names that you don't recognize of the metabolites. When I first looked at my first 24-hour urine report, I went, oh my God, this is like a mountain to climb to learn about this. Because once you start testing someone, like an endocrinologist who's treating patients with diabetes, they're going to be so at home
in that world
with the sophisticated testing that you can do for diabetes. You can do a fasting insulin, you can do a fasting glucose, you can do a hemoglobin A1C, you can do a 2-hour glucose tolerance test, you can do an extended glucose insulin tolerance test. There are these exquisite tools, and they're doing this day in and day out. And these folks, they look at those results and they see what's going on there. But it took them quite a while. That's quite a learning curve to do that many patients. It took me, I was saying the other day, that it took me 50 24-hour urine hormone tests where I finally started to breathe a sigh of relief. I was starting to understand what they were. But it doesn't matter. These labs are so fantastic that they've got someone who will help you interpret it. And then anyone in the menopause method, I help our providers interpret them. And you need them. And this is why it's been such a slow. This is why the 24-hour urine hormone test is not well known and it's not popular. And when I first thought of asking a patient to collect urine for 24 hours who had kidney stones, just to measure their stone calcium and magnesium and other things that might be making stone, I thought, God, that's too much to ask them to collect their urine for 24 hours. And that's one of the most common complaints I hear, is I can't ask a patient to collect their urine for 24 hours. Well, yes, you can. If you know it's the right thing to do, they can do it at home. They don't ever have to leave their home. collect the 24-hour urine, prepare the final sample, and call UPS. It's easy to do when a patient knows that you know it's important. So 25 years of asking women to do this, I don't get any pushback. Zero. Okay, once every 10 years, I hear something like, wow, that was a lot.
May I ask you something?
Sure.
A woman comes in, she's been in menopause for 10 years. Are you going to test her right off the bat that day?
Absolutely not. And that's a great question. What am I going to learn?
Yeah,
She gets to pay money to learn what we already know for 100% certainty, that her hormone levels are extremely low.
right.
I did that when I first started out, but I didn't do it many times. She told me the symptoms. It was obvious that she was super low. I asked her to do a 24-hour urine hormone test. I learned that she was super low. I got to tell her that.
Yeah,
Fancy doctor says, look at this test, you're super low. Oh, she got to pay $290 for the
right.
privilege of me telling her what was already going on. No, it's not helpful at all. Good question. But it's all of us, every human being. I find we don't know what we don't know. And when a doctor leaves medical school or is out there practicing, we know what we know. If we don't know, then a 24-hour urine hormone test, and we're hearing that blood testing and saliva testing don't work, your doctor is likely to say to you, well, we don't want to test you because we're not going to learn anything. Plus, we can learn by symptoms alone. Well, I believed in that, but I was always testing. But then one year before Dr. Wright and I taught at a large holistic organization called A4M, every year prior to doing this, I said, well, what have I learned in the last year? And so what I did is I pulled up 54 24-hour urine hormone tests on women in my practice from that year who said to me, wow, I think I found my right dose. I feel really good. I was feeling really not good. Now I feel really good. And that's when we test 100% of the women in our practice, 100%, every single one of them. That's my favorite time to test. It's not the only time we'll test. But when a woman says, wow, I think I've got my doses figured out, fantastic, I feel good, then we test them. And here's what I learned. 25% of the women that we tested, when they're saying, I feel really good, were actually in the zone, the optimal zone, as extrapolated from the medical literature, not too much and not too little. 50% of the women they said, I feel good, but they were not on sufficient estrogen to protect their vagina and their bones. It takes a certain amount. We know what those numbers are. They weren't on enough.
Right.
They were close, but they were not on enough. 50% of them said, I feel good. And yet, with the levels that they were showing on the 24-hour urine hormone test, they were going to lose bone and they're going to lose their vagina.
Ew.
We don't lose your vagina, but the vagina gets so thin, and then that leads to bladder problems. That's not even to mention the arteries in the brain. 50%. I feel good. They were on too low. And 25% were on what I would consider to be too much estrogen. That means they're putting their breasts at risk for breast glandular cell proliferation, for cellular mitosis. That's a very vulnerable time in a cell. Not so much for a young woman who's got a healthy immune system and can identify mutated cells, more so for a woman in her 50s. She's undergoing breast glandular cell mitosis. That's a vulnerable time for her. So, yes, I understand that physicians, good meaning physicians, loving physicians, and nurse practitioners, they really care about medicine. They really care about their practice, but we don't know what we don't know. And there's very, 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 very few physicians and nurse practitioners that are specializing in menopause. So they've got these broad-based practice. Menopause is a small part of it. They never can put in the time and energy to really get great at hormones. Well, we're wanting to change that. the menopause method has many different moving parts, and one of them is encourage folks to specialize. We've developed standard of care. We're working on creating a board certification. So it's a recognized specialty, just like endocrinology is, just like orthopedic surgery is. And we're training and mentoring physicians and nurse practitioners.
And thank you so much for doing so, because we need it. Menopause is a specialty. And I just have to say, God bless that you do what you do. And I do see the time.
It is a hard stop today.
It's always a hard stop.
Yeah.
Yeah.
So I'm going to see you on
Next week,
Tuesday.
on Tuesday, yes, mitosis. That's right, Rod. Dr. Rosensweet, always thank you so much. So good to see you. Welcome to all the fabulous women here, the men who don't say their names, but I know you exist. Wishing everybody a great weekend. I'll get to the questions on Tuesday, and just enjoy.
Bye-bye, Carolyn. Bye-bye, everybody.
Dr. Rosensweet. See you later, all.
See you later.